morning, Chairperson and dear delegates. Myself, Dr. Mohsin. I'm Assistant Professor from Government General Hospital, Guntur. So the talk was given to me is on DUTASTERIDE, evolution to 2023. I just want to emphasize on the basics of DUTASTERIDE, and next I want to quote few recent papers. No conflicts of interest. So this is DUTASTERIDE, belongs to this synthetic steroid, and the above is the chemical name, and you can see the molecular structure and the IUPAC name given below. It was patented in 1996 first, and it was in 1997 it was in first scientific literature. It was approved by FDA in 2001, and the patent was expired in 2015. After that, it was available as a generic formulation, usually available in a soft gelatin capsule, which is 0.5 mg. 60% bioavailability of DUTASTERIDE, and it's 99% protein bound. Its main metabolism is liver. It has 3 metabolites, 4,6 hydroxydutasteride and 1,2 dihydrodutasteride. Its elimination half is a bit longer. It's 4 to 5 weeks. I'll mention it in my next slide. And majority is excreted in the feces, is 40%. As we all aware, it belongs to class of drug 5-alpha reductase inhibitor. This inhibits and prevents conversion of testosterone to dihydrotestosterone, which is an active form of testosterone. It inhibits all 3 forms of 5-alpha reductase inhibitor, DUTASTERIDE. So it is efficacious, and it reduces dihydroxytestosterone levels up to 98%. Whereas finasterides block only type 2 and type 3, hence it can reduce up to 65 to 70%. Due to accumulation of testosterone to peripheral conversion, we can all evidence these side effects. Inhibition of, usually these enzymes theoretically will feel that there will be increase in testosterone. But there is a paper in Sexual Medicine Reviews published in 2019. So this paper says that it concludes that 5-alpha reductase inhibitor therapies are not associated with a consistent and significant increase in serum testosterone levels. As we all know these effects, it improves urinary symptoms, IPCA score will be improved, flow rate will be improved, and decreased chance of urinary retention, and reduces progression to surgery, and decreases PSA value by 50%. So first it was approved for BPS therapy, and in prostate cancer, it's in chemo prevention, many trials are going on. And it's used in androgenic alopecia, and it's used in hirsutism as well, which is off-label prescription. And it's in hormone therapy in case of transgender women. These are all adverse effects, which we see: loss of libido, erectile dysfunction, depression, reduced semen volume, and gynecomastia, and menstrual changes in the women. Contraindications: pregnancy is contraindicated. As I mentioned, this can be used in hirsutism, and it causes ambiguous genitalia and undermasculinization of the male fetuses. And the people on DUTASTERIDE should not donate blood, as well should not donate blood even after at least 6 months after cessation of the therapy. As I mentioned, that the half-life is, drug long elimination is very long for this drug. I'm coming to papers. This Indian paper in Journal of Endourology published in 2017. That is on transurethral resection of prostate. This is a prospective randomized double-blind control study, short-term use of finasteride, DUTASTERIDE before surgery. And the study design is, as I mentioned, randomized into 3 groups, 150 in each group. First group received placebo, and second group finasteride 5 mg, and third group DUTASTERIDE 0.5 mg. Therapy was for 4 weeks. The outcomes, what we look for: total blood loss, requirement of blood, and microvascular densities in the prostate stroma. It's histopathological. The results were like this: the significant reduction in mean blood loss time, and total blood loss per gram of the resected tissue in the finasteride DUTASTERIDE group compared to placebo. And there is a prostate stromal microvascular density was significantly lower compared to placebo, and blood transfusion rate was very low in case of DUTASTERIDE, that is 2%. In conclusion, a 4-week prior administration of 5-alpha reductase inhibitors may reduce operative blood loss and reduce in the prostatic microvascular densities in the case of TURP specimens. And the second study is a Japanese study. It's published in 2022, efficacy and safety of DUTASTERIDE with tadalafil add-on therapy in patients with LUTS secondary to BPH. So the objective is to evaluate the efficacy and safety of add-on therapy with tadalafil with patients who are already on monotherapy with DUTASTERIDE. Sample size is 24 patients with 50 years age group who are on already the monotherapy with DUTASTERIDE for more than 6 months. It's a retrospective observational study. The tadalafil 5 mg is given daily. Outcomes like IPSS, quality of life score, OAB, symptom score, SHIM score, Qmax and PVR, everything checked at baseline of the 4 weeks, 12 weeks, or 24 weeks. It was measured. Here we can notice here IPSS score as well as quality of life score improved gradually for 12 weeks, then up to 24 weeks. And total OAB symptom score as well as SHIM score improved at 24 weeks. The post-void residual urine gradually reduced as well as flow improved. To conclude, the add-on therapy with tadalafil was effective for patients with LUTS, BPH, resistant to DUTASTERIDE monotherapy. In addition, this therapy was not associated with any severe adverse events. And another paper from same Japan published in 2022, the phase 2 trial of abiraterone with the DUTASTERIDE for a second generation anti-androgen and a chemotherapy naive patients with CRPC. The objectives were to evaluate the efficacy and safety of adding DUTASTERIDE to abiraterone and identify candidates suitable for combination therapy. Samples of 21 patients who are on ADT. It's a phase 2 single arm and open label study. A patient received abiraterone and prednisolone for 4 weeks, followed by adding DUTASTERIDE to it. A primary endpoint is to look for 50% PSA rate, and secondary endpoints were to treatment failure and safety. This slide shows like 86% patients achieved more than 50% reduction in PSA with the treatment. And there is during a median follow-up of 16 months, 7 patients experienced a treatment failure. There was no difference in time to treatment failure between non-metastatic as well as metastatic CRPC. To conclude, there is a favorable efficacy of combination therapy with abiraterone and DUTASTERIDE accompanied by anticipated safety profile. That to a short-term study with a limited number of patients, and promising outcomes warrants further investigation with large randomized trials. And this paper from JAMA Oncology in 2022, this is the association of 5-alpha reductase inhibitor with prostate cancer mortality. The question is the use of 5-alpha reductase inhibitor associated with risk of dying of prostate cancer in healthy men? So the findings are in this, the large population-based cohort study of 3.5 lakh without a previous diagnosis of prostate cancer, users of 5-alpha reductase inhibitor had a lower prostate cancer mortality after a long treatment duration for the benign prostate hyperplasia. Interpretation is that this cohort study found an association between treatment with 5-alpha reductase inhibitors and reduced mortality in prostate cancer, suggesting that these drugs are safe to use regarding the risk of CA prostate. And coming the final paper published in European Urology Focus in 2023, this understanding the treatment response in individual profiles of men with prostatic enlargement at a risk of progression. The objectives were to understand the treatment response in individual profiles of men with prostate enlargement at a risk of progression. Our sample size is 9,000 patients with, who are at risk of progression. It is a 3 placebo-controlled DUTASTERIDE trials on which one is compared with DUTASTERIDE, tamsulosin, and a combination of DUTASTERIDE and tamsulosin. The duration is of 48 months. The outcomes looked were IPSS score, prostate volume, urinary flow rate, maximum flow rate, and a PSA, PVR, and usage of alpha blocker for 12 months, and a randomized treatment, and time to progression to surgery. So the results were like this. The vast majority of the patients benefit from DUTASTERIDE or combination therapy when compared to tamsulosin alone. The predicted IPSS improvement with DUTASTERIDE or combination therapy increased with the prostate volume. The tamsulosin effect was lower with greater baseline prostate volume and tend to decrease over time. And predicted risk for surgery was greater with tamsulosin versus this combination. And the increased risk with the larger prostate volume, higher PVR, and lower Qmax, low flow rate. So to conclude, the risk factors of the disease progression interact and affect response to different treatments, reinforcing the importance of an individualized approach for LUTS management. I thank you. Thank you, Sanjay sir and IPCA for giving me this opportunity.